I wanted to understand, first of all, how people make treatment decisions, especially with AML. They're acutely diagnosed. In other words, they feel well today and tomorrow they could find out they have acute leukemia. So it's a high stress period. And then they have to digest the diagnosis and then understand what the treatment options are within a few days or sometimes within a day, and then make a decision to start. And then sometimes that require being in the hospital for a month. So you have to do that all within 2 or 3 days. And it's even harder in older adults. So younger adults, typically the decision is a little bit more straightforward. You go for the more aggressive therapy, and then you stay in the hospital for a month. Versus in older adults, there's more to that. So for example, some people may have limitation doing activities at home, maybe bathing or requiring help with medications. And we know some studies have shown that having limitation in some of these things, such as activities or mood or nutritional status, such as weight loss, can predict outcomes. So there are two reasons why I did this. First was to understand how decisions are being made in the first place, with the hope that could I then create some tools to help facilitate decision making during that stress period. And then my other passion is trying to figure out how we can better assess fitness in this population, and hopefully to also incorporate the tools that we know could help determine fitness for both patients and oncologists. And that information could potentially then lead to a better decision for both parties, because oftentimes what happens is you're guessing the fitness level. You don't really have time to assess fitness during that high stress period. And then you make a decision in like 24, 48 hours. So there I think many things that go into that. And obviously the practice pattern is also different being in a university setting versus community, because traditionally the treatment is mostly inpatient. So if your oncologists don't have the infrastructure or support to give that treatment in an inpatient setting, in the past, you just don't get treatment. Now, at least in the last 15 years, but in the last few years, more and more outpatient therapies that have benefits or can provide benefits to older adults have been approved by the FDA. So more and more patients, older patients at least, could get treatment. But the practice pattern is definitely different depending on who you see first, where you present, and whether the facility you present to actually have the capacity to do the treatment. So if you talk to different oncologists or if you get care from different areas, I think the practice pattern is a little bit different depending on what infrastructure they have. And it's not that they don't want to do it, it's just that they some of them may not treat patients in the hospital. So they just couldn't do it. And the next closest hospital may be like 5 hours away. So some older adults would rather stay closer to home and then forego treatments that may be curative, and vice versa. Actually, you might live close to the hospital and then see someone who is a bigger proponent of intensive therapy in the hospital. And even though you're not that fit to get that therapy, because you're there, you're more likely to get that therapy and die from it. So both under treatment and over treatment are problems in this population. So there are two areas. So two main findings from this study was that I found there are more than 60 things that could affect decision making in this population. Some of this may be perceived more important than oncologists, some by patients, and there are some things that are perceived as important by both parties. And then I also figure out what the potential barrier is to incorporating some of this fitness assessment. And that's pretty consistent with other studies in other cancer population, in terms of the barriers such as lack of education, lack of time, lack of resources. The biggest surprising finding that came out of this was I was trying to figure out how people pick getting treatment in the hospital versus getting treatment in an outpatient setting, and whether they were given that option or those options, and most actually did not remember that they discussed the various option, and most just say they had no choice and just went with that option that was recommended by the oncologist. So that was interesting because the whole point of me trying to do this was to figure out what are important for people, and then what are the pros and cons of the different treatment when they think about the treatment that they went through, but they didn't even feel like they actually went through that. They just went with the treatment that was recommended. At least that was what was perceived by the patients, which I don't think is necessarily true. I think it was just during that stress period, you just don't retain the things that your oncologists tell you, right? People only retain maybe 10 to 20% of the content that was communicated. So even though there were options presented to you, I don't think people actually got that. So what I got out of the study was that I'm trying to create a communication tool to hopefully first capture the fitness information, and then second, try to incorporate things that are important to both oncologists and patients and help them navigate through the stressful period and come up with a decision that both parties are happy about so they don't have regret later.